gram per deciliter. So now again, what is the cyanosis? It's bluish discoloration of skin and the mucous membrane due to increased reduced hemoglobin more than 5 gram per deciliter. Okay, this is cyanosis. But what are the types of cyanosis? Central and the peripheral, right? Or mix. It may be central only, and maybe peripheral only, and maybe mix. Yes, sir. But later on. So the cyanosis may be central cyanosis, maybe peripheral cyanosis, or maybe mixed cyanosis, which is very important to the pediatrician. Is the central cyanosis or the peripheral cyanosis? Central cyanosis. Why? Because it is more dangerous. Because it is more dangerous. What are the common sites for to inspect the central cyanosis?
Cardiopulmonary.
Yes. What is the part of the tongue? Base of the tongue. Not the ventral surface, the dorsal surface of the tongue. Base of the tongue. And what the parts of lips? The inner lips. This is the inner surface of lips. And yes, mucous membrane of eyes, conjunctiva and skin. These are the most important sites to be examined for the central cyanosis. What about the peripheral cyanosis? Where the common sites, the extremities, palms and foot, nails of fingers and toes. These are the common sites to inspect the peripheral cyanosis. Today we will discuss the central cyanosis, not the peripheral cyanosis. And I said why? Because central cyanosis is more dangerous and it is more common. So today we will discuss the definition of central cyanosis, and we already discussed it, and we will transfer to the second point, which is the etiology of central cyanosis, and then how to examine child with central cyanosis, and how to investigate, and how to treat. This is the first half of the lecture. What are the causes of central cyanosis? What are the causes of central cyanosis? Usually, cyanosis, as we said in the definition, is mainly due to increased reduced hemoglobin. So, who can sensitize the oxygen and supply the body with oxygen? Lung. Lung is the site of manufacture, right? Site of absorption, site of supplying, site of distribution. But who distributes the blood? So the main factor to form oxygen and supply the body with oxygen is the lung. So the most important causes are usually related to the lung. And the causes regarding lungs are usually can be classified according to the site. According to the site. Usually we have the respiratory system started by nose, and then pharynx, and then larynx, and then trachea, bronchi and bronchioles, and then lungs and pleura. These are the and even the diaphragm. These are the respiratory system. If we started by the nose, we will have in unit what is called bilateral choanal atresia. Bilateral choanal or choanal atresia. Bilateral choanal atresia can produce cyanosis, especially when during feeding. No. During the crying, cyanosis disappears. If the child opens his mouth, he will take his breath from the mouth. So he will bypass the obstruction. So the cyanosis will improve by crying and worse by feeding. This is the most important number one bilateral choanal atresia. And then we will go to the larynx. Laryngeal obstruction, say by meconium or foreign body, or meconium or laryngeal web or ring. All these are anomalies which can produce severe cyanosis due to obstruction of the passage of the air through the larynx. Then we will go to the trachea and bronchi, what is called laryngotracheomalacia or laryngomalacia, which is weakness in the wall of this passage, which will lead to obstruction of the passage of air to the lung. Then we will reach to the lung itself. The lung itself, the most important cause, number one, is hyaline membrane disease. Number two, pneumonia. Number three, transient tachypnea of newborn. Number four, meconium aspiration syndrome. So, in the lung, we have 4 items. We will discuss it all today. That's very important. Number one, hyaline membrane disease or respiratory distress syndrome. Number two, transient tachypnea of newborn. Number 3, pneumonia. Number 4, meconium aspiration. Then we will transfer to the pleura and pleura or pleural disease like air or water. That's pneumothorax or hydrothorax. Pneumothorax or hydrothorax. And then the last thing, which is very important, regarding the diaphragmatic paralysis. Diaphragmatic paralysis. It may be due to brachial palsy or Verding-Hoffmann disease. Verding-Hoffmann disease. Due to the diaphragmatic paralysis may be due to Verding-Hoffmann disease or brachial palsy. These are the respiratory causes. So we will start again by the nose. What are the most important causes?
Bilateral choanal atresia.
Right. Regarding the larynx, what are the causes?
Laryngomalacia.
Right. Foreign body, laryngomalacia. Laryngeal ring, right? Lung, respiratory distress syndrome, meconium aspiration, pneumonia, transient tachypnea of newborn, diaphragm, brachial palsy, Verding-Hoffmann disease, pleura, blood disease, voice, pneumothorax, and hydrothorax. Okay, pneumothorax, and hydrothorax. These are the respiratory causes of central cyanosis in neonates. Now we will transfer to a very important another organ which is very important in oxygenation and in distribution of oxygen to the whole body and in push the blood to all parts of the body, which is the heart.
My heart.
The causes of cyanosis at birth or during the neonatal period are summarized in an abbreviation called 5T. 5T. So we have 5 cardiac disease started by the letter T. Number 1, transposition of great arteries. Number 2, total anomalous pulmonary venous drainage. Number 3, trunks arteriosis. Number 4, tetralogy of Fallot. Number 5, tricuspid atresia. These are the 5T which are responsible for central cyanosis in newborn. Again, number 1, total anomalous pulmonary venous drainage. Number 2, transposition of great arteries. Number 3, trunks arteriosis. Number 4, tetralogy of Fallot. Number 5, tricuspid atresia. Okay. So the last one on the left, doctor, yes. What are the cardiac causes of central cyanosis?
Transposition of great
Tetralogy?
tetralogy,
Tetralogy of Fallot?
tricuspid atresia,
أيوة.
trunkus arteriosus,
Trunks arteriosis.
total anomalous pulmonary venous.
Total anomalous pulmonary venous drainage. Okay. This causes, suppose that you already took it in Al Hussein Hospital, right? Okay. So now we will transfer to the third organ, which is the headmaster of all process. Who is the headmaster of the body? The CNS, the brain. The neurological causes of central cyanosis will be on the top is hypoxic ischemic encephalopathy. Number 1, hypoxic ischemic encephalopathy. Number 2 is intraventricular hemorrhage. Number 1, hypoxic ischemic encephalopathy. Number 2, intraventricular hemorrhage. Number 3, CNS infection like meningitis or encephalitis. Number 4, drugs, especially anesthetic agents or mother addiction. If there's drugs transmitted from the placenta to the fetus. And the last is seizures and congenital brain anomalies. Seizures and congenital brain anomalies. These are the central causes of central cyanosis. Please, yes sir, what are the central causes of central cyanosis? Number 1, hypoxic ischemic encephalopathy, intraventricular hemorrhage, CNS infection like and encephalitis. Yes. Drugs. Right. Right. Excellent. Number 1, 2, 3, 7, 8,
أيوة
9, 10, 10.
Examination.
Don't say anything. 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 1, 22, 3, 4, 5. Now we will discuss the other causes of central cyanosis. The other causes for central cyanosis include number 1, hematological disorder, especially methemoglobinemia, and polycythemia, and metabolic causes which are also common and very important, especially hypoglycemia and hypothermia. Hypoglycemia and hypothermia. And the last cause is infection like C. Then the causes or the etiology of central cyanosis are divided to 4 causes. Number 1, respiratory. Number 2, cardiac. Number 3, CNS. Number 4, others. Others are 3: hematological, polycythemia, methemoglobinemia, metabolic, like hypoglycemia, hypothermia, and infection like this. These are the causes of central cyanosis. Now, if there is any question regarding the definition and the etiology of central cyanosis, Eisenmenger syndrome, yes, but it is a complication, it's not a disease. It is a complication for reversal of the shunt. When the shunt is left to right, no cyanosis. If the shunt is complicated due to pulmonary hypertension, due to long standing, or due to failure of the left side, and the pressure increase in the right side, it will causes increase of the blood shifting from the right to the left. From the right to the left. In this situation, the cyanosis will be clear, and the condition is called Eisenmenger syndrome. The Eisenmenger is a complication, it's not a disease. Any question?
Why is hypothermia is good?
And at the same time, it will not occur in units. Yes, we discuss the causes of cyanosis in units. Eisenmenger will not occur. Because Eisenmenger to occur, it takes a very long time, years, to make the effect and the shunt reversal. Instead from left to right, to be right to the left. And usually it takes a long time.
Why is hypothermia is good and metabolic cause?
All right, because it usually causes a lot of metabolic changes, especially freezing of the cell and prevent ATP release. So it is a metabolic cause. And at the same time, it can be a general cause. Any question? Now, if you are facing a child neonate with central cyanosis, what are the steps for diagnosing the possible etiology and how to assess the condition of this child? Number 1 is the examination. After taking a brief history about if there is any maternal drugs intake or the type of anesthesia, and brief history about any antenatal problem which can affect the neonate and produce a problem, you will examine the newborn. Number one in the examination is to identify if the cyanosis is central or peripheral. And at the same time, you have to identify if there is cyanosis or not firstly. Because any newborn, during straining, if he's trained like this, this baby, his face may be soft and may be mildly cyanotic. But it's not cyanosis, it's not really cyanosis. So most of the mothers will say that their baby during this training is cyanotic. But this is not actually cyanosis. So the first problem to be solved during examination is number one, to see if there is cyanosis or not. If this is true cyanosis or pseudo cyanosis. If it is true cyanosis, you have to identify is it central or peripheral. This is number one. Number two, you find a cyanosis already. You examine the baby and you found a cyanosis. So your mind will revise the possible causes of cyanosis. The possible causes of cyanosis starts by the lung, heart, sickness, and then others. So regarding the lung, all causes of lungs are usually produce respiratory distress and the fast breathing. So you will clinically count the respiratory rate and you will clinically look for the signs of respiratory distress. What are the signs of respiratory distress in units? Number one, tachypnea. What is the meaning of tachypnea?
Increase heart rate.
Above 60.
No, 60 or more, not above. Not only above. I mean started from 60. Because above 60, it means 60 is not included. But 60 is included. 60 or more. This is number one, fast breathing. Number two,
Grunting.
okay, start from here.
Working Alanas.
Right, walking and result. Number two. Number three, grunting. Number four,
Suprasternal.
cyanosis.
Okay.
Cyanosis, don't forget. Number five, what?
Suprasternal.
Suprasternal retraction. Number six,
Intercostal.
intercostal retraction. Number seven,
Subcostal.
what is called
Chest and drawing.
chest and drawing. Hey, excellent. Chest and drawing. These are the 7 signs of respiratory distress. Okay, so please, sir, stand. Yes, sir. Stand by. Can you tell me what are the signs of respiratory distress in units?
First, working alanazal.
No. Number one, respiratory rate.
Respiratory.
Fast breathing.
Tachypnea.
So you tachypnea. How you if you count the respiratory rate will be
60 and above.
60 and above. Number one. Number two.
Working alanazal.
3.
Grunting.
Grunting.
For cyanosis.
Cyanosis.
Chest retraction.
Suprasternal.
Suprasternal.
And intercostal retraction. And
Subcostal.
which is called
Chest syndrome.
excellent. Excellent. Sit down. This is the if you examine and you found all signs or some signs of respiratory distress, your thinking will go directly to the possible lung causes. At this time, you will examine the chest clearly, inspection, palpation, percussion, auscultation, and after finishing and reaching a possible diagnosis, you will order for X-ray chest, posterior anterior. Okay? And in X-ray, you will find the possible cause. You may find pneumonia, you may find ground glass appearance of hyaline membrane disease. You will find pneumothorax or hydrothorax. You will find
Foreign body.
diaphragmatic hernia. You will find the possible cause of respiratory distress, and at the same time the possible cause of central cyanosis regarding the lung. But you examine the lung in other situation and you found nothing. No distress and no fast breathing. So is the lung still as a cause?
No.
No. You will shift to
Cardiac.
the heart.
Cardiac.
You will examine the heart thoroughly. You will count the heart rate, and you will examine the heart inspection, palpation, percussion, and auscultation. And any murmur present will encourage you to go through this way. And at this time, you will do
Ultrasonography. Echo.
echo. You will make echo and
Ultrasonography.
no ECG,
ECG.
because echo is ultrasound. Echocardiogram is ultrasound, but it is ultrasound to the heart. That's it's called echocardiogram. And at the same time, you will make ECG. This is a very important cause. But you examine another situation. You examine the heart, and you didn't find anything. In this time, you will go directly to the CNS. You will examine the anterior fontanelle and the child consciousness, and you will make a complete, thorough CNS examination. Usually, if the cause is in the CNS, you will find signs. You will find alteration in the level of consciousness. You may find hypertonia or hyperreflexia, and you may find continuous sharp crying of the newborn. In this situation, you will put the possibility of
Central lesion.
What are the causes of the central cyanosis regarding the CNS? Number one, hypoxic ischemic encephalopathy, intraventricular hemorrhage, CNS infection, drugs, seizures, anomalies. Hypoxic ischemic encephalopathy is diagnosed by called ABG. You will find metabolic acidosis plus CNS manifestation like seizures plus multi-organ system affection. Interventricular hemorrhage, how to be diagnosed?
Interfontanelle.
Cranial ultrasound. How can you diagnose neonatal interventricular hemorrhage? Cranial ultrasound. Clear? Cranial ultrasound. CNS infection, how can you diagnose? No.
Temperature.
Lumbar puncture and CSF examination. Lumbar puncture and CSF examination. Anomalies. CNS anomalies by
X-ray.
cranial ultrasound or CT or MRI. But usually we prefer to make only cranial ultrasound to avoid the hazards of the CT. These are the CNS, but you examine the central nervous system and you found the baby is completely normal. So he is, regarding the chest is normal, heart is normal, and CNS is normal. You will put the possibility of other causes. So you will look for the baby color to see if he is polycythemic or not, and you will order CBC to see the hematocrit. When you can say that this child has polycythemia, if the hematocrit value is
above
above
14.
65.
65.
If the hematocrit value is above 65. But you did CBC and you found normal CBC. So you will go to the metabolic causes, you will make or you will order for immediate blood glucose to see if there is hypoglycemia or not. But you did, and the blood glucose was normal. In this situation, you will put the last possibility is septicemia, infection. And the infection can in neonate present without any signs, except that the newborn does not look well. Except that the newborn does not look well.
How about fever?
No fever. Usually the neonates presented with infection have the opposite, have hypothermia, not hyperthermia, due to lack of the control of the heat regulating center. So it can usually or commonly manifested by hypothermia, not hyperthermia. If you suspect infection, you will order CBC, micro ESR, CRB, and the blood and urine culture. Blood and urine culture to see if there is possibility of infection or not. These are the how to examine a newborn and how to investigate a child with cyanosis. Before going to the treatment, if there is any question? Any question? No? It means everything is clear or everything is unclear? Unclear? Is clear or unclear?
Clear.
Clear. Okay, inshallah. Now, what are the treatment of central cyanosis? Firstly, it is symptomatic. You have to correct immediately the defect regarding the increased reduced oxygen in the blood. So you have to give him a
Oxygen.
So oxygen will be given to the newborn by any way regarding immunity. You may give by head box, by nasal bronch, by mask, by CPAP, continuous positive airway pressure, or by mechanical ventilation. So you have to provide a sufficient amount of oxygen to correct the cyanosis by any way before treating the cause, because that's emergency and cyanosis can distract the brain. So please, the most important thing is to save the child and to save his brain by giving it oxygen by any one of these ways: by head box, nasal bronch, CPAP, or mechanical ventilation, up to mechanical ventilation. And then you can go to the possible etiology and treat it. If it is the lung due to infection or hyaline membrane disease, you can give the Sulfanta. Infection, you can give the antibiotics. Meconium aspiration, you have to aspirate the meconium from the focal cords, from the cords before first breath, and so on. This is regarding the lung. Regarding the heart, the most important thing is in all cyanotic heart disease, the 5T, you have to keep the shunt open. If there is shunt, you have to keep it open because it is the only way to change the blood. So how to keep it open? By giving prostaglandin. By giving prostaglandin E. Prostaglandin, which is called prostaglandin E, to prevent closure of the ductus arteriosus, especially in TGA. If the cause is hypoglycemia, it's very easy. You can give glucose infusion, and you can, in case of polycythemia, you can make exchange transfusion. If the case is hemoglobinemia, you can give vitamin C. Vitamin C 200 to 500 milligram per 24 hours for NAD cytochrome B reductase deficiency and methylene blue. You can give methylene blue initially 1 to 2 milligram per kilogram per 24 hours, followed by oral methylene blue 3 to 5 milligram per kilogram per 24 hours for toxic methemoglobinemia. Remember that the treatment of methemoglobinemia is methylene blue. You
Methyl.
remember methylene blue?
Stain.
It is a dye, yes, it is a dye. Of course. In some cases, you need urgent surgical intervention, especially for diaphragmatic hernia and choanal atresia. Diaphragmatic hernia and choanal atresia or choanal atresia. I finished the first part of the lecture, which was about the central cyanosis. Any question? Yes.
Doctor, what is TGA?
What about
What is TGA?
Transposition.
transposition of great arteries?
You say about the shunt. Do you mean it the
About what?
shunt? Shunt. Shunt.
The shunt.
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 You mean PDA?
No, that's arteriosis. Yes.
And you said that the treatment is prostaglandin.
Yeah. You will give her a prostaglandin.
But prostaglandin will facilitate PDA closure.
No.
Prostaglandin.
Tak.
Prostaglandin will keep the duct open. Prostaglandin will keep the duct open, especially in case of
TGA.
that is depending congenital cyanotic heart disease like TGA. Because in case of TGA, the
Incompatible.
aorta arises from the right side, and the pulmonary arises from the left side. So there is complete separated circulation. One to the body and one to the lung, and there is no mix. The only way to mix is
Pattern.
the ducts arterioles, which is shunt between the pulmonary trunk and the aorta. If this duct is closed,
Die.
and how to close the shunt? By
Bukan prostaglandin.
how to close the shunt?
Spontaneous.
By endomethacin
Yes.
or
Ibuprofen.
ibuprofen or
Stricture.
dysentery
Stricture.
acetaminophen.
Paracetamol.
Acetaminophen, paracetamol. These drugs close the ducts, but prostaglandin
Patent.
patent the ducts or open the ducts. But at the same time, prostatin or prostaglandin have a very serious side effect, which is hypertension. Hypertension, and they may produce apnea. So very carefully if you get prostatin or prostaglandin.
Doctor, what is truncus arteriosus?
Truncus arteriosus is an obstruction in the aorta, in the main bulk of the aorta, that prevent the blood to push from the ventricle to the whole body.
In neonate only or in adults also?
In any age, but it is commonly in unique.
Doctor, what drugs that cause central cyanosis,
Anesthetic agents,
such as
anesthesia.
anything?
Yes, any anesthetic agent in a large dose or overdose can produce cyanosis.
VSD is a cyanotic.
Sorry?
VSD.
VSD? No, it's acyanotic. Any more questions? Everything is in the, understandable. Everything is واضح, clear.
Alhamdulillah.
Alhamdulillah. So the second part of the lecture will be about the lung causes of
Respiratory disease. Neonatal cyanosis.
neonatal central sinus. The lung causes of neonatal central sinus will be number one is
Hyaline.
hyaline membrane disease or respiratory distress
Stress
syndrome.
syndrome.
This is the most common respiratory disorder in neonates, or even the most common respiratory disorder in neonates. It's very, very common and at the same time very, very important.
Mm.
It's very common in preterm.
Mm.
What is the preterms?
In 35 weeks.
Before 37
7
weeks. Before 37 weeks. Now we have factors which increase the risk of hyaline membrane disease, and we have another factors which can decrease the risk of hyaline membrane disease. So we have two factors, factor and its antagonist. We have factors already commonly can trigger and increase the incidence of occurrence of hyaline membrane disease, and at the same time we have another factor which decrease the incidence of occurrence of respiratory distress syndrome. Can you please come here? Why you are so far? Yes, please come here. Okay, it is broken.
Yes.
Okay. What are the risk factors which increase the incidence of hyaline membrane disease? Anyone knows?
Preterm.
Number one, preterm. This is a very important fact. Number one. Number two, cesarean section. Number three, diabetes mellitus. These are the main risk factors. These three. Uncontrolled diabetes mellitus, cesarean section, and preterm. These causes are usually very, very important as a causes or risk factors for occurrence of respiratory distress syndrome. And these factors are usually present in any uncontrolled diabetes mother. In diabetes, you have to deliver early, so he is preterm. In diabetes, you have to deliver by cesarean section, and she is diabetic. So the risk factors are very common, and that's why any diabetic mother have a very high risk of hyaline membrane disease for her baby. These are the first important C. Number four, without explanation, male sex. Male sex. We don't know why, but male sex is usually have a higher risk of hyaline membrane disease or respiratory distress syndrome. Number five, which is important, is perinatal asphyxia and the multiple pregnancy. Perinatal asphyxia and the multiple pregnancy. Perinatal asphyxia is usually a risk factor, and the multiple pregnancy is usually a risk factor. These are the factors which increase the incidence of hyaline membrane disease, and these are called risk factors. These are called risk factors. What about the factors which decrease the incidence of occurrence of hyaline membrane disease or respiratory distress syndrome? Number one is intrauterine growth retardation. Number two, prenatal steroid. Prenatal maternal steroid. If you give the mother 1 dose or 2 doses of steroid, prednisolone or beside prednisolone, usually can prevent occurrence of hyaline membrane disease and increase
The risk.
senses of surfactant. and the maturation of surfactant. This is number 2, and it's very important. Number 3 is hypertension. Number 3 is maternal hypertension. Maternal hypertension is a factor which can decrease the risk of hyaline membrane disease. Also, the intrauterine stress, especially if it's chronic intrauterine stress due to decreased blood supply to the fetus from the placental infection or infarction or any cause which can decrease the blood supply to the fetus and produce fetal distress, chronic intrauterine distress. These are the most important 3 factors, plus the maternal pulmonary disease or abused mother or narcotic use. These are the most important factors which decrease the risk of hyaline membrane disease or respiratory distress syndrome. Again, we will research what are the risk factors of hyaline membrane disease. Prematurity,
diabetic mothers,
yes,
male sex,
male sex,
cesarean
cesarean section,
prenatal
perinatal asphyxia, multiple pregnancy. Excellent. What are the factors which decrease the incidence of respiratory distress syndrome? Yes. Hypertension. Excellent. Intrauterine starvation. Narcotic drugs. Very important, perinatal steroid. That's very important, perinatal steroid. Perinatal steroid. Don't forget perinatal steroid because it is a method of prevention. It is a therapy, drug, perinatal steroid. These are the causes, the risk factors which increase the incidence, and at the same time the factors which decrease the risk of occurrence of hyaline membrane disease. Any question? Yes, sir.
Why the narcotic use?
Why?
How the narcotic use decrease risk?
Narcotic will suppress the respiratory center, decrease the risk of fast breathing, and decrease the distress.
Doctor, can you give example of chronic intrauterine stress?
Can you give what?
Example, chronic intrauterine stress.
I said placentitis and the placental infarction, which decrease the blood supply to the fetus. Decrease blood supply to the fetus will cause fetal distress.
I mean, as what infarction? What makes the infarction?
What means the infarction? It may be hypertension, maternal hypertension, and at the same time, chronic maternal illnesses. If she has chronic renal failure, that will decrease the blood supply to the placenta and will produce chronic intrauterine stress.
But again, how does a diabetic mother increase the incidence of the disease?
Uncontrolled diabetes, because hyperglycemia can injure the lung tissue and prevent surfactant formation and can destruct the surfactant.
What about hypertension, doctor? What kind?
It decreases the blood supply. And the decreased blood supply will enhance the lung to maturate, to produce surfactant.
What about normal infants? Does it decrease the risk of hyaline membrane disease?
Usually, the hyaline membrane disease is a disease of prematurity. Because I will say after this, in the next slide, that surfactant is completely manufactured and released completely at 36 weeks. So any newborn delivered 36 weeks or more will not suffer from hyaline membrane disease because the surfactant is completely manufactured and completely active.
The therapy we give to all mother or just a suspected mother?
What?
The steroid therapy
Yes.
to the all mother or the suspected mother only?
No, it's in Egypt now it's supposed to be given for all mothers. Any question? Okay. What are the etiology and the pathophysiology of this etiological cause of respiratory distress syndrome? It is thought that the cause of developing respiratory distress syndrome is lack of formation of surfactant. Lack of formation of surfactant. Surfactant, where it is sensitized,
Lung.
where in the lung,
Alveoli.
in alveolar cell type 2.
Type 2.
In alveolar cell type 2. What is the chemical composition of the surfactant?
Lecithin.
It is formed of lysine sphingomyelin. It is phospholipid. It is phospholipid. Lysine sphingomyelin by ratio 2 to 1.
2 to 1.
2 lysine to 1 sphingomyelin. It is 2 to 1. And sensation or sensitization of any other abnormal ratio will not act and will not be beneficial and they can't used by the receptors. So it is important to be sensitized by this ratio, lysine to sphingomyelin 1, to form one part of surfactant. Is surfactant is important?
Yes.
How?
Prevent
Why it is
collapse.
important?
Prevent epilepsy. Prevent collapse.
How?
Increase surface tension.
Extension.
Decrease or increase?
Increase.
Increase surface tension?
I think so.
Increase.
Decrease surface tension. Okay. Please, I will explain. Quick. You know that intrauterine life, the lung is
Not functioning.
not functional, but it is collapsed or aerated. Huh?
Dormant.
If it is collapsed, it will not be open. Whatever the child, it will not be open. And at the same time, it's not aerated, but it contains only up to its third level alveolar fluid. Alveoli, every alveoli contain up to its third size fluid, interstitial fluid or alveolar fluid. This alveolar fluid is present intrauterine antenatally. Why? To keep the alveoli open and to enhance aeration after birth. But the problem is, what is the problem?
Cannot synthesize.
The surface tension of fluid is more than or is higher than the surface tension of air. So air can't push fluid. But the opposite is right. Fluid can push air. Right? At birth, what I want and what I need something to reverse this flow. to make the surface tension of the water or the fluid is less than the surface tension of the air. To let the air to go to the alveoli and push the fluid to the interstitial space. Who will make this work? The surfactant. Clear?
Alhamdulillah.
Alhamdulillah. And this is the only minute or second in which the law is changing for the child's sake. The surface tension of the fluid is usually higher than the surface tension of the air. And if this law is persistent, the child will not take his breath because the alveoli contain fluid. In this condition, Allah subhanahu wa ta'ala will sensitize or will lead the alveoli to alveolar cell type 2 will sensitize the surfactant. This surfactant will change the law only at birth. Immediately after birth will let the surface tension of the fluid to be less than the air, and at this time and by this mechanism the air can push the fluid, and this is the only event which can occur at this moment. So just after delivery the surfactant is ready, and with the first breath of the baby the surface tension of the fluid will be decreased by the action of the surfactant, and the air will push the fluid to the interstitial space, and the alveoli will be filled with air. This is how the etiology or how the surfactant can work, and why, if it is not working, the child will develop
Cyanosis.
hyaline membrane disease or respiratory distress syndrome. Clear?
Alhamdulillah.
Now we know that surfactant is very important, and in any newborn will be delivered prematurely, we need to know if he has a sufficient surfactant or not. If we want to know prenatally, we can do what? Prenatal assessment or measuring the surfactant in amniotic fluid sample. You can take sample from the amniotic fluid and you can or just